Hello everyone, my name is Dr. Lorena Martinez. Today I will be teaching you the basics of performing a point-of-care cardiac ultrasound. As we go through the presentation, please keep in mind that the sonographic examples of cardiac pathology will be discussed in a separate lecture. So let's get started. I do not have any financial disclosures. Our goals for today are to review the 4 point-of-care cardiac ultrasound views, which are the parasternal long axis, parasternal short axis, apical 4-chamber, and Subxiphoid views. We also want to learn the proper placement of the ultrasound transducer on the chest to obtain the aforementioned views. Be able to identify various structures in each view. And finally, learn how to obtain the inferior vena cava longitudinal view from the Subxiphoid and right over quadrant approach, as well as assess its size and respiratory variation, and use this information to determine the patient's volume status and guide the fluids resuscitation. There are several indications to performing a point-of-care cardiac ultrasound. Some of the most commonly encountered can be found in this slide to include chest pain and any of its associated symptoms, as well as procedural guidance like in the setting of a pericardiocentesis. Okay, so to start with our preparation to obtain our cardiac images, we're going to place our patient in the supine position and lay the head of the bed completely flat. However, keep in mind that some patients may be in respiratory distress or having a heart failure exacerbation and may not necessarily tolerate laying in a flat position. Therefore, in those kind of situations, I want you to try to do your best to obtain the needed cardiac views, essentially in whatever patient's position of comfort, in order to answer your clinical question. Now, if you're having any difficulties obtaining any images in the supine position, the best next thing you could do is actually lay the patient in the left lateral decubitus, as this motion is going to bring the heart away from the sternum and then closer to the chest wall, which is going to allow you to visualize the cardiac structures a little bit better. When it comes to the ultrasound machine, we're going to proceed by selecting the phased array transducer. This is also known by many or recognized by many as the cardiac probe. This particular probe is ideal for our cardiac views because it has a low frequency of about 2 to 4 megahertz and a small footprint, which is going to allow for the ultrasound waves to not only penetrate deeper, but also for the actual probe to fit between the reed spaces. After you select your probe, you're going to have the option to select what we call a preset. So you could have different presets such as the cardiac preset, the abdominal preset, the ocular preset. And these particular presets are going to have the, let's say, optimal settings like gain, depth, thermal index, or mechanical index already preset in that particular selection so that your images could be obtained with the best possible settings, in other words. Now, I want you to keep in mind that when you select the cardiac preset, you still might have to manually optimize your settings, like your gain and your depth kind of deal, in order to get the best images possible. Also, keep in mind that in the cardiac setting, and I'm also going to talk about this a little bit more on the next slide, but in the cardiac setting, the actual ultrasound marker on the screen is going to be set on the right side of that particular screen. This is very different from almost all the other presets on the ultrasound machine, which may have the indicator marker sitting on the left side of the screen. So here's just a quick picture of a patient laying on the supine position. This is like the optimal position that you want to obtain your cardiac views. And then again, if you're having difficulty visualizing the heart in this position, you could just simply have the patient lay in the left lateral decubitus. I also have them sometimes bring their arm up underneath their head because it allows for opening of that rib cage on the left side, which gives you a little bit more space to fit your probe. This is a picture right here of the phased arrayed transducer. You can see it has like a very small square footprint right here that could easily fit in between the ribs. And lastly, I'll show you a small video of myself selecting the phased array transducer here and then going into the cardiac preset. And then I failed to show you that in that previous preset, the indicator was actually on the right side of the screen. But as you can see on this particular video, when we get to that cardiac preset, you'll see that the indicator sits on the right side of the screen. And that's going to be important, and you'll see why. Finally, let's take some time to talk about the nitty-gritty of the different focused cardiac ultrasound views that you need to obtain to have a complete bedside point of care cardiac ACM. Here's a quick overview of the 5 main point of care cardiac ultrasound views that we're going to be discussing today and their widely recognized abbreviations. I want you all to keep in mind that this list is purposely organized in a systematic approach that I personally use, and essentially everybody in the emergency field probably uses, as it's easier to maneuver the probe from the first view to the next, essentially. So we're going to go through parasternal long axis, followed by parasternal short axis, then apical 4-chamber, subxiphoid, and finally the inferior vena cava view. Also, I added here one of my favorite cardiac point of care ultrasound schematics from the Renal Fellow Network, which I love because it shows you the probe position and the corresponding image that you're going to get while placing the probe in that particular area of the chest. Here's a parasternal long axis view, which is the first cardiac ultrasound view that we're going to obtain, as it gives you a good overview of the overall general condition of the heart, including information such as ejection fraction and overall left and right ventricular sizes. To obtain this view, we're going to place the cardiac probe on the 3rd or 4th intercostal space left to the sternum, with the probe marker, which is right over here, facing towards the right shoulder of the patient. The 3rd and 4th intercostal space is about at the level of the nipple line in males and the inframammary folds in females. The structures that are going to be visible in this view include the left and right ventricles, the left atrium, aortic and mitral valve, and ascending and descending aorta. In this view, we're going to have the chance to assess for the left and right ventricular size and function, gross abnormalities of the visible valves, such as the mitral valve and the aortic valve, pericardial effusion and tamponade physiology, left atrial size, pleural effusion, and ascending and descending aorta pathology. This is a 3D model that I borrowed from University Health Network Virtual Transthoracic Echocardiography website to help you visualize the positioning of the probe in relation to the chest and heart to produce the desired 2D ultrasound image. As you're about to appreciate, there is a green line right here. Let me grab my probe pointer. So this green line right over here. So keep in mind that green line here pertains to the probe indicator, which is pointing towards the patient's right shoulder. Therefore, any structures on the side of the probe indicator will be reproduced on the right side of the ultrasound screen, which is where the ultrasound marker indicator is found. Remember again that the ultrasound marker indicator is on the right side of the screen. So right here where the green dot is found. This side of the screen corresponds to the side of the probe marker indicator is pointing to. In this case, the probe marker indicator is pointing to the right shoulder or right superior aspect of the patient. Therefore, the right side of the screen is showing the structures of the heart that are found in the right superior aspect of the patient in relation to the position of the probe. So in this case, if you remember correctly, probe is in the 3rd, 4th intercostal space, left sternal border. Therefore, structures that you could find facing towards the right side of the shoulder will include the aorta, as well as the left atrium. On the left side of the screen, you will see structures sitting on the left inferior aspect of the patient or towards the patient's left hip in relation to the probe position. So that would be the left ventricle in this case. The near field, which is essentially if you cut the screen in half, we could call this right here the near field and this right here the far field. So the near fields are going to have the most anterior structures, or the structures that are closer to the probe because the probe is sitting up here. So in this case, it'll be the right ventricle. And then the far field will have the structures that are deeper to that. So in this case, we'll find the left ventricle right here. Let me just clean up the screen for a second. So in the posterior or far field, we find the left ventricle, the left atrium, as well as the mitral valve right here. Okay. So before we start talking about all these structures to a little bit more detail, I want to remind you all about the importance of having enough gain to visualize the different chambers of the heart, as well as enough depth to include the descending aorta in the far field. So descending aorta is back here, and you want enough depth so that this is included in the picture, as the descending aorta is going to serve as an anatomical landmark for the differentiation between the pericardial and pleural effusions, which we're going to discuss in a separate video. So, like I mentioned before, the structure visualized here include the right ventricle in the most anterior aspect of the image. We have also the left ventricle right posterior to that, and the left atrium separated by the mitral valve right here. Right here, you can see the anterior leaflet of the mitral valve. And this one is going to be an important anatomical feature because we're going to be looking at this anterior leaflet for signs of heart failure, essentially, or decreased ejection fraction. Other things that we can use to evaluate the heart for possible decreased ejection fraction is also looking at the thickness of the septal wall, as well as the free left ventricular wall right here. So you can see that in this particular heart, both walls are thickening evenly and pretty well overall. So just eyeballing this heart, we know that the anterior mitral valve leaflet is slapping the septum, and we see that both walls are having very nice equal thickness, and it's very nice and concentric overall. So we know that this heart is probably having a normal ejection fraction just by qualitative analysis. Another discussion that we're going to have is the E-point septal separation calculation, which is going to be discussed in a separate video by my colleague. This is also known as EPSS, and this uses the mitral valve anterior leaflet excursion to estimate the ejection fraction in the parasternal lung axis view. Here we can also appreciate the size of the right ventricle, and in this case you can tell that the right ventricle is about maybe 2/3 of the whole left ventricular cavity, right? So that is normal. Another useful tidbit that we can also use to determine if the right ventricle is dilated versus not is that the right ventricle is usually the same size as the aorta and the same size as the left atrium. So that's what we call kind of like the rule of third, right? So right ventricle is 2/3 of the left ventricle size, and then it is also the rule of thirds in the sense of these three structures right here are essentially the same size in a normal heart. If the right ventricle was to be about the same size as the left ventricle, then we can say that the right ventricle is moderately dilated. And if the right ventricle was bigger than the left ventricle, then we can say that the right ventricle is severely dilated. Lastly, we should also look for anechoic fluid representing pericardial effusion around the heart. So we can look for anechoic fluid here, and we can look for anechoic fluid back over here. And then again, my colleague is going to discuss in a separate video how we're going to use the descending aorta to differentiate between a pericardial effusion and a pleural effusion. And last but not least, I don't want you to forget looking at the descending aorta for any signs of dilation or mobile flaps that could represent aneurysm or dissection, respectively. Sometimes when trying to acquire the parasternal lung axis view, you can actually end up with a heart that looks like it's slanted upward. To actually fix this picture and obtain the ideal horizontal parasternal axis view, like we saw in our previous slide, all we have to do is move your probe from the position where you're at to a more cephalad position, so essentially jump to the rib space above. And this should help bring that heart in a more horizontal plane. And once you get to that position, depending on the patient, you might have to do some slight fanning like I just did here by tilting that tail of the probe towards the left shoulder of the patient. So parasternal short axis view is going to be the next view that we're going to obtain. It's often abbreviated as PSSA or PSAS. To obtain this view from the parasternal long axis view, all you have to do is rotate your probe to 90 degrees clockwise so that the probe indicator is now pointing to the left side of the shoulder of the patient. Usually when obtaining the parasternal short axis view, the first parasternal short axis level that is going to come into view is the mitral valve level. This level is also known as the fish mouth view, as the opening and closing of the anterior and posterior leaflet of the mitral valve resemble the opening and closing of a fish mouth. From there, you can fan the probe either up or down to obtain the other two parasternal short axis levels, which are the aortic valve, also known as the Mercedes vein view, due to the three cups of the aortic valve forming a star like that of the Mercedes-Benz emblem, and lastly the mid-papillary level. And I'll show you guys how we're going to obtain these views by tilting our probe either up or down. Lastly, this particular view, the parasternal short axis view, is great to assess for regional wall motion abnormalities in the setting of a myocardial infarction, for example, or to look at the left ventricular systolic function overall, as well as the right ventricular size, and look for right ventricular heart strain, and lastly pericardial effusion as well. So structure in the middle of the screen, as you can see in our initial video. Let me go back. If we pause it right here, we could see that the middle of our screen is sitting more or less past the mitral valve, kind of at the level of like probably the chordic tendinae / papillary muscles. So when we rotate here, as I'm doing, you can see that I'm rotating the indicator to the left side of the patient or the left shoulder, so it was just a 90 degrees clockwise this way. So as I rotate, the first structure that's going to pop up in my screen, as you can see, was kind of like a hybrid of like mitral valve and papillary muscles right here. So I'll show you guys again. We could see a little bit of that mitral valve coming to view initially, and now we only see the papillary muscles. So oftentimes it is the mitral valve that we actually see when we do that rotation, because usually people are centered right over that mitral valve. So what I'm trying to allude to is whatever is centered on your screen is the first thing that you're going to probably see when you turn from your parasternal long axis to your parasternal short axis. Just like our previous 3D model, you can see here that our green light again belongs to the probe indicator in this particular model. So you can see how it points essentially towards the left shoulder of the patient, and how this particular rays are going through the heart in a transverse, right, or a short fashion. So we're kind of slicing that upside down cone in half and having an upper and lower half, right? So if you remember correctly, the green line here pertains to the probe indicator again, which points towards the left side of this patient. So any structures on the side of the probe indicator will be reproduced on the right side of the screen, where our ultrasound marker indicator is found. So in this case, as you can see, the left side of the heart is going to be seen on that right side of the screen, and we will see that in the next video. Here's one of my favorite pictures from POCUS 101 website of the parasternal short axis views. So like I mentioned earlier, oftentimes when we're transitioning from the parasternal long axis into a parasternal short axis, the first view that is going to come into place is the mitral valve view, because that's often where the center of the screen is as we're rotating, right? So whatever you have center on the screen is the first thing that's going to appear. So if you have the papillary muscle center on your screen, when you rotate from the parasternal long axis in a clockwise fashion to the left shoulder, then you're going to first see the papillary muscles in that case, right? But if we're, most of the time, most people are usually centered over the mitral valve, and that's why this is the first view that they get when they do that rotation from long to short. So simply to obtain the aortic valve view that I mentioned earlier, all you have to do is tilt or fan the tail of the probe towards the base of the heart or towards the feet of the patient, if that helps visualize that motion, and I'll show you more or less in a few videos. And then if you want to go from a mitral valve level to a papillary muscle level, you can either sweep slightly away from the sternum, and that could give you this view, or also tilt that tail of the probe or fan that tail of the probe towards the head of the patient, which will direct the rays essentially down this way and give you this particular picture right down here. Here I just have a quick sweep of all three levels of the parasternal short view. So here you have the aortic valve going into mitral valve right there, and eventually to papillary muscles. So again, aortic, mitral coming into view right there, and then papillary muscles. Okay, so the mid papillary level, as we can see here, is great to get some information of the overall ejection fraction / left ventricular systolic function. So we can see a very nice concentric squeeze of that left ventricle. And you can also look here for left ventricular renal wall motion abnormalities. So in the setting of a myocardial infarction, you could see if there's any particular wall that is having less motion as compared to the other ones. You could also look at right ventricular heart dysfunction, and some of the signs that we can appreciate in the setting of right ventricular strain or heart strain is what we call a D sign, in which this septum right here, instead of looking nice and round, is going to be essentially bowing into the left ventricle and making this particular nice and round ventricle look like a D, which we'll see in another video again. And then we can also look for pericardial effusion, so that nice anechoic black line going around the heart. So from the papillary views, again, if we slide the probe slightly towards the sternum, or we simply tilt that tail of the probe down towards the feet, we can appreciate the mitral valve level or the fish mouth view of the parasternal short axis. Here we can see the anterior leaflet of the mitral valve, and then the posterior leaflet of the mitral valve. So we can assess those to make sure that they're moving appropriately. Additionally, we can also assess for right ventricular and left ventricular size and function, just like we did in our previous papillary level. And we can also look for left ventricular regional wall motion abnormalities, as well as pericardial effusion. Here we have the last level that we're going to be discussing for the parasternal short axis, which is the aortic valve level or the Mercedes-Benz view. In this particular view, we're going to have the opportunity to look at the right atrium and the right ventricle to determine their sizes and function. In between the two, we can also see the tricuspid valve, as well as catch a little glance over here of the pulmonic valve, and we can also look for abnormalities of those. We can also perform more advanced echocardiography here, such as the pulmonary acceleration time, which is going to help us determine if there is an acute versus chronic etiology of the right heart strain, such as, for example, PE versus a pulmonary hypertension, respectively. We can also look at the aortic valve right here and look for calcifications, which will appear as a very intense hyperechoic or bright collection along the cups of the valve. And we can look for other abnormalities, such as like a bicuspid valve, right? Instead of seeing 3 cups, we'll see only 2. Lastly, we can look at the left atrium for its size and function. And like we have mentioned in other videos, we can also look for an anechoic or black collection around the heart that will symbolize a pericardial effusion. The apical four-chamber view is probably one of the most challenging views to obtain as a novice sonographer, but it is also one of the most important views to be able to obtain when doing hemodynamic assessments of the heart, such as diastolic dysfunction, valvular regurgitation, and cardiac output. From the parasternal short axis view, all you have to do is sweep your transducer towards the apex of the heart with the probe indicator pointed toward the left flank of the patient. The apical four-chamber view will be acquired approximately somewhere inferior to the nipple in males and under the left breast in females. Once you have reached the apex of the heart, all you have to do is essentially fan the tail of the probe down towards the patient's feet to just open up those atriums. Likely, you'll have to optimize the gain and the depth on your screen to visualize the 4 chambers of the heart, as the depth that you were using for your parasternal short is likely not going to be sufficient to catch all 4 chambers. So this particular view is probably one of the main views where you may want to have the patient lay in the left lateral decubitus position if you're having trouble getting the apical four-chamber appropriate view. Again, this particular maneuver tends to kind of move the lung artifact out of the way and then bring the heart closer to the ultrasound probe, which allows you to visualize the cardiac structures a little better. Lastly, in this view, you can assess for left ventricular and right ventricular size and function, valvular pathology, pericardial effusion, pericardial tamponade, ventricular hypertrophy, as well as atrial enlargements. So again, from the parasternal short axis, all we're doing is sweeping down underneath the nipple in this particular male and turning the transducer towards the left flank. And as you travel down, you can see that the heart kind of disappears and then appears again, and then you start seeing the atriums in the far field of the screen. And then remember, in this case, I had already optimized the gain and the depth for this particular patient. You can see that I went down to 15 versus in the previous images, if you rewind the video, you can see I was somewhere around 10. Again, I know I probably sound like a broken record by now. Every single time I show these 3D images from the University Health Network virtual transthoracic echo webpage. But I want you to all appreciate the green line here that belongs to the probe indicator. And as you can see, we're coming from the apex of the heart and kind of also cutting the heart in a longitudinal aspect. But now the closer structure to the near field of the screen is going to be the apex because that's the closer structure to the probe. And then what we're going to be seeing on the right side of the screen where the ultrasound marker indicator is found is going to be the left side of the heart. So essentially, if I rewind this video just a tiny little bit and we go here, this is essentially the picture that we're going to get, is that the probe is sitting right in the middle of the screen. So again, just to reiterate what we said a few seconds ago, remember that the ultrasound indicator marker is sitting towards the right side of the screen. So this corresponds to that green line that we saw on that previous slide, which was sitting on the left side of the patient, right? That probe marker was going towards the left side of the patient. So all that means is that the right side of the screen is the left side of the patient. Therefore, the left side of the screen is the right side of the patient. And again, the closer structures to that probe were the ventricles, and that's what you're seeing here in the near field of the screen. And on this far field of the screen, you're seeing the deeper or more posterior structures, right? Which are the atriums. So if you just happen to not remember everything that I just said, and you don't remember which side is what, another tidbit that you can potentially use is that the tricuspid valve sits a little bit closer to the apex. So you'll see that this valve right here is essentially just a little bit more inferior, essentially, as compared to the mitral valve, just where they come from off the septum. So in this particular view, again, we can appreciate all 4 chambers and we can assess for size and function of all 4 chambers. We can also look for valvular pathology, right? So we can look for vegetations. We can throw some color Doppler to look for regurgitation. And then we can also do other calculations that are a little bit more advanced to determine like pressure gradients between the different chambers and the velocities of the flow through the valves. And lastly, again, like I keep mentioning in every picture, we can assess for pericardial effusion. Now, oftentimes when we are trying to obtain the apical 4-chamber view, we accidentally end up obtaining something that looks like a 5-chamber. And the reason why it's a 5-chamber is because it has the aortic outflow tract or the aortic valve coming into view. And at times we can also obtain something that looks like this, which is our coronary sinus views, in which you can see that coronary sinus kind of transversing that posterior aspect behind the atriums, right? To then eventually dump into the right side of the heart. So how can we fix this? Easy peasy. So if you have an apical 5-chamber, like we did like 2 seconds ago in this view, all we have to do, or all that means is you probably have your hand way too flat, or the tail is essentially way too down towards the feet of the patient. So all you have to do is a slight, maybe 5 to 10 degree tilt of that tail towards the cephalad position, just like you see here. So like, again, it's a very minimal, very slight motion just to open up those atriums and get rid of that aortic valve. So again, you see my hand slightly coming upwards like you see here, and that will take the picture from having that aortic valve to then disappearing and having your 4 chamber like you have here. In the contrary, if you accidentally obtain the coronary sinus view, like we have here, all we have to do is the opposite of what we did for the apical 5-chamber view. So in this case, all that means is the tail of your probe is too cephalad, so you have to fan it down slightly just to get a view of your atriums. So again, you could see it's a very slight motion that I'm doing over here. I go from being a little bit more perpendicular to the skin to just dropping my hands ever so slightly. And that will go from having this coronary sinus to opening the atriums like you see here. So we have finally made it to view number 4 out of 5, and this is the subxiphoid or subcostal view. And this view tends to be pretty useful, especially when having difficulty getting adequate parasternal views, like in the setting of our COPD patients who have hyperinflated lungs that might be obscuring your cardiac views and not allowing for the ultrasound beams to travel through. So to obtain this view, we have the patient in the supine position and the head of the bed flat. And we're going to place the transducer with the indicator towards the patient's left flank in the subcostal region right below the xiphoid. It is very important to keep in mind that our probe is going to be parallel with the skin in order to get this view. So you have to grab the probe from an overhead kind of grip, and I'll have an example of that in the next video coming up. And in this view, we're essentially going to see similar structures as the ones that we saw in the apical 4-chamber view, which includes the left and right ventricle and the left and right atrium with the corresponding valves in between. And again, the same assessment that we did in the previous image, we could do in this one. So here you can see a video of myself with that overhand grip that I mentioned earlier that will allow me to drop that probe as low as possible to obtain my subxiphoid view, as I mentioned before. So once again, we have our 3D model here to show you the positioning on the probe in relation to the heart and how we're slicing that heart. You can see that the 3D probe here inferiorly is slicing the heart in a longitudinal fashion, just from a different angle, right? So now we're coming from below. And remember that the green line corresponds to the pro marker, therefore whatever structures of the heart is sitting closest. Let me pause the video right here because this is a perfect picture right here. So green line, pro marker, therefore whatever structure is sitting closest to that green line is going to appear on the right side of the screen, right? So in this case, it's going to be the apex of the heart. And then just remember, if we divide the screen in half, we're going to have what we call the near field. And then posterior to that is going to be the far field. So the field further away from the probe. So in the near field, or the closest thing we're going to find closest to that probe, is going to be the liver, because that's where we have the probe, right? So we're using the liver as an acoustic window to help us get those rays across and to the heart. And then in the posterior field, we're going to find the heart with the closest chamber to the liver being the right ventricle. And then posterior to that, we'll find the left side of the heart. So left atrium, left ventricle. So again, here we have our subxiphoid view with our ultrasound indicator sitting on the right side of the screen. So that's where we're going to find the left of the patient, because if you remember, our probe indicator is pointing towards the left of the patient. So that's where we're going to have our apex. So this is the right side of the patient. The closest structure to our probe now is the liver, and that's what you're seeing here. And lastly, the most posterior structure in the far field of the screen is going to be the left atrium, which is the most posterior structure of the heart. And then the corresponding valves in between the two atriums and then the ventricle. Now, here you can also appreciate a little bit of lung curtain coming into view. So that's one of the troubles that we're unfortunately gonna potentially run into when we're getting a subxiphoid view. So sometimes to try to get rid of this lung curtain, all you have to do is essentially slide your probe slightly towards the right side of the patient so you can use more of the lever as your acoustic window to allow those ultrasound ray beams to travel and hopefully get a view of that apex. Last but not least is the inferior vena cava view, which can be used to estimate central venous pressure as well as fluid tolerance in our patients. To obtain this view, we're going to go from the subxiphoid view, which has the probe indicator towards the left side of the patient, and then rotate that probe 90 degrees clockwise so that the probe indicator is now towards the feet of the patient. You may have to rock the probe slightly upwards so you can actually visualize the right atrium and where the IVC is coming into the right atrium. And you should be able to also visualize the hepatic vein inlet going into the IVC. A proper evaluation in this view entails actually assessing for both the size or diameter of the inferior vena cava and its collapsibility with respiration. I also wanted to point out the difference in physiology in terms of the inferior vena cava diameter in spontaneously breathing versus ventilated patients. So in spontaneously breathing patients, recall that during inspiration, the abdominal pressure increases while the intrathoracic pressure becomes more negative, which leads to a lower right atrial pressure. The hemodynamic counterpart to the aforementioned thoraco-abdominal interaction is the increase in blood return from the IVC to the right atrium, leading to a reduction in the size of the IVC and a transient increase in stroke volume. Conversely, venous return decreases during expiration or exhalation, while the IVC diameter increases. To summarize, in spontaneous breathing patients, remember that the maximum IVC diameter will be during expiration and the minimum IVC diameter will be during inspiration. The contrary happens in ventilated patients, where the positive end expiratory pressure may hamper the venous return during inspiration by increasing the intrathoracic pressure and reducing the pressure gradient between the abdomen and the thoracic compartments. This leads to a maximum IVC diameter during inspiration and a minimum IVC diameter during expiration in ventilated patients, which is the opposite that we're seeing with the spontaneously breathing patients. So why is it so important to assess the IVC diameter on inspiration and expiration? So assessment of the IVC provides the most evidence-based surrogate of volume status compared to other large veins by measuring the static diameter of the IVC as well as the dynamic respiratory fluctuations of the IVC. So again, just showing you here that from the subxiphoid view, in which I had the probe marker pointing towards the left side of the patient, all I did was rotate 90 degrees in a clockwise fashion to bring that probe marker to the feet of the patient, as you can see right there. Now, I did a little bit of rocking as well, in which I kind of brought those, you could see myself dropping that hand down a little bit, so I can bring that right atrium into view a little more. Now, I also wanted to mention that if you were to rotate your probe 90 degrees counterclockwise, you can also obtain the same exact view. This means your probe marker is going to be facing cephalad, meaning this will be up and this will be down in that kind of situation. So all you're doing essentially is flipping the image in which you're putting the right atrium on this side of the screen, and the IVC will be coming from inferior to superior. And again, this is actually that last view that I mentioned in which the pro indicator is pointing cephalad, so that the right side of the screen on the ultrasound will be superior or cephalad, and the left side of the screen will be inferior or caudal. So you kind of will get that view here in which you're going to see that the right atrium will be the one to be sitting on the right side of the screen in that kind of situation. The opposite is true if you were to rotate that pro marker inferiorly. This is the inferior vena cava with the pro marker directed caudally, meaning the right side of the screen where the pro indicator is corresponding to the inferior aspect of the patient. As for the left side of the screen correspond to the superior or cephalad aspect of the patient. So I wanted to bring up the point of being careful not to confuse the aorta and the IVC in this view. If you were to slightly sweep towards the left side of the patient, you can easily visualize the aorta entering the thoracic compartment. There are a few features that could be helpful and could be utilized to confirm that you're actually looking at the inferior vena cava instead of the aorta. First, you should actually visualize the inferior vena cava entering the right atrium like you see here, as opposed to the aorta, which will be essentially traveling behind the heart. Other features that you can use is the hepatic vein, which we see coming into the inferior vena cava, and some of the liver right here in the far field of the screen behind the inferior vena cava. If you were to be looking at the aorta, what you're going to see is the vertebrae and then an anechoic space behind those vertebrae, as the rays don't tend to travel behind bone. Lastly, inferior vena cava should also have some level of respiratory variation, but this is limited in the setting of a high central venous pressure. Know that the exact point at which the IVC diameter should be measured is crucial, but unfortunately is not universally standardized. In a spontaneous patients, variation in the IVC diameter are smaller, usually near the right atrium IVC junction right here, and they tend to be the largest in about 2 centimeters distal or caudal from the hepatic vein inlet, so about somewhere around here. So most literature suggests that the measurements should be acquired within 1.5 centimeters from the hepatic inlet, so somewhere maybe around here before that greatest area of variation. This is a table that was adapted from Kircher et al. That translates the IVC diameter and the collapsibility index to estimate the central venous pressure in a non-invasive fashion. These can be useful to evaluate for fluid tolerance and the presence of venous congestion. However, I want you all to keep in mind that there are limitations, and all the limitations that essentially apply to central venous pressure also pertain to these measurements of the IVC. And then there are going to be other limitations that we're going to discuss in a couple more slides in terms of the numbers in the middle. So the numbers in the low aspect of CBP, and the high CBPs are a little more accurate, but when it comes to these numbers in the middle, they're obsolete. Now, in the case of a suboptimal or unavailable subcostal window, a coronal transhepatic scan along the mid to posterior right axillary line may be an effective alternative to look at the IVC. This is essentially the same location where we evaluate the right upper quadrant in a focus assessment with sonography in trauma, or what we know as the FAST-SAM. But the probe is angled slightly down towards the bed to be able to catch the view of the inferior vena cava. In this particular view, I just want you to be careful when you're calculating the diameter and collapsibility in this view as surrogates for volume status, as the IVC phasic variation mainly occurs in an anterior to posterior plane. Here we have a quick video of how to obtain the maximum and minimum diameter of the inferior vena cava by using what we call the M mode or motion mode. Again, like I mentioned earlier, the preferred position is probably going to be about 1.5 centimeters caudal from the hepatic inlet and prior to the area of most respiratory variation. This was just simply an example. As you can see here, the IVC that I have on this video is slightly diagonal as opposed to more horizontal, which is important when it comes to the measurement of the diameters of the IVC, as having a more diagonal IVC could lead to a overestimation of the diameter and therefore the erroneous assumption that the patient volume status is on the higher side. When it comes to the IVC, there are some pitfalls that you should all keep in mind. So several confining conditions can cause IVC dilation as well as IVC flattening. And this could end up resulting in misinterpretation of volume status. So remember to take that into account when utilizing your IVC diameter to determine your patient's volume status. Remember that the measurements of the central venous pressures that sit outside of the low or high central venous pressure, so that middle portion of that table that I showed earlier, are considered indeterminate, and you should be careful when applying this information to your patient. And lastly, if you're going to utilize a mode to measure the IVC diameter, it is important to obtain a horizontal view of the IVC as to not end up overestimating or overcalculating the diameter and having false assumptions of your patient volume status. Oof, so we finally made it to the end of our video. I want to thank you for sitting with me for the past hour, but I wanted to leave you with some pearls before we parted away. First one is, remember that one view is no view. So if you have a particular view that is not necessarily optimal, just try the others. In a perfect world, we'll have 5 out of 5. They all look great, but in reality, we do not live in a perfect world, and that applies to your patients too. Most of the time, you're only going to be able to see great cardiac windows maybe in 2 out of the 5 views, and that should be probably enough to answer your immediate clinical questions to determine your assessment and plan for this particular patient. Same goes for pathology. If you find something, make sure you're getting different views or planes of this particular pathology so you can, again, kind of determine what it is. And last but not least, if possible, have your patient hold their breath briefly when needed to get rid of the lung currents. And this particular applies to the parasternal short access, where you could have your patient fully exhale and then hold their breath while you take a video of your clip, right? And then you can have your patient breathe, and then you can replay your video and take a look at it to determine if you're seeing any particular pathologies. Here are my references. And last but not least, if you have any questions, please feel free to email me at lorena253@usf.edu. Thank you so much for tuning in, and I hope you were able to learn something about how to perform a point of care cardiac ultrasound.